Um, Today we are here to discuss about one of the very favorite topic of European Board College ESHRE guideline endometriosis, which has come up in 2022, the revised form. So we are here to discuss the most important point for the part one people. You will get one-liner questions, SBAs, as well as EMQs from the slides I have put here. So we will be quickly revising the guideline, though it's a huge one, but I have tried to take out all the important points for the purpose of exam. It will also help part two people and people who are preparing for OSCE, MRCOG to quickly revise their guideline. So shall we start now? Mm, okay. So first of all, let me introduce myself. I am Dr. JP Kaur, and I am MRCOG, and I have done my European Fellowship. I'm European Fellow for Obs and Gynae, um, and I'm a mentor at Rayz Academy for EFOG EBCOG group, and we all welcome you here in the class. Okay, on behalf of Academy, I welcome you. So starting from now, this is the endometriosis guideline 2022. We are starting here. What is endometriosis? We all are very well aware of that. This is the implantation of endometrium outside the uterus. So many theories are there, but retrograde implantation theory is the most commonly accepted one. So this is the picture I have put to show the right ovarian endometrioma, and it is a chronic inflammatory disease. So it generally affects the woman of reproductive age group because the growth of endometrium is estrogen dependent. But it can also uh, be there or remain there in postmenopausal women. So the prevalence of endometriosis, it is a common condition. 2 to 10% is the prevalence, but in infertile women, it is up to 50%. So that was an SBA last time in the EFOG Part 1 exam. Prevalence of endometriosis in the infertile woman. So for the diagnosis of endometriosis, what does guideline says that we have to take the clinical history. Previously said gold standard diagnosis, that was diagnostic laparoscopy. This time they have said no, that's not the gold standard. We have to we can diagnose the condition on clinical basis as well. And if we find the sign and symptoms, these are the dysmenorrhea, deep dyspareunia, dysuria, dyschezia, and the cyclical symptoms of extra pelvic endometriosis as well. That's the pneumothorax, catamenial pneumothorax, cyclical cough, hemoptysis, chest pain, and the cyclical scar swelling and pain, and cyclical fatigue and infertility. Among that, pain is the cardinal symptom, which is the most commonly found. So, based on the sign and symptom, clinician should be getting the suspicion of endometriosis and can start the treatment. If clinical suspicion uh, for this, if the clinician is suspicious for endometriosis diagnosis, they can add the diagnosis with the help of symptom diary or questionnaires or the app that can help in objectifying the pain. Supporting your clinical history findings with the clinical examination. The importance of examination is very much because vaginal examination to identify the deep nodules or the endometriomas in patient with suspected endometriosis. Along with the clinical examination, even if you do not find anything in clinical examination, that does not rule out endometriosis. you have to support your clinical findings with the imaging studies. In imaging studies, there are transvaginal ultrasound scan and MRI scans. It should be considered in suspected endometriosis, even if the clinical examination is normal. Use of biomarkers, that is CA-125, though it is easily available and cheaper as well, but the sensitivity and specificity both are very low for diagnosing endometriosis. So their use is not being recommended by the GDG, that is Guideline Developing Group. A negative imaging does not rule out endometriosis as well. If patient has clinically significant symptom, patient can be offered laparoscopy, and endometriotic lesions should be confirmed by histology. But negative histology does not rule out the disease. So on the basis of suspicion, the patient should be given the treatment for the endometriosis. Patient should be throughout given the psychological support in case of confirmed endometriosis and follow-up. Now, there are different categories of the problems that are related to endometriosis. Like the most cumbersome is the pain, which we are worried about. So in that situation, NSIs or other analgesia, pain management clinics are there to manage the pain which is associated with endometriosis, and the hormonal treatment. It can be combined hormonal contraceptive, it can be progestogens, it can be GnRH agonist or antagonist. If we are using combined hormonal contraceptive in the patient with endometriosis associated pain, continuous use is recommended because we do not want to the cycles to happen and the further shedding of the endometrium in the endometriotic implants, which give rise to pain. So continuous use of combined hormonal contraception, vaginal ring or transdermal patch. It reduces the endometriosis associated dyspareunia, dysmenorrhea, as well as the non-menstrual pain. So all these are the one-liner questions and the EMQs questions that I have put here in the highlighted here. Guideline says that levonorgestrel intrauterine system or the etonogestrel releasing implant, it reduces the endometriosis associated pain as well. GDG says never to use oral danazol for treating the pain. Okay. So GnRH agonists, they are prescribed as second line treatment. So that's again a question. They are the second line treatment because of their side effect profile. So combined hormonal add-back therapy alongside the GnRH agonist therapy to prevent bone loss and the hypoestrogenic symptoms should be considered if we are choosing GnRH agonist for the pain relief. In case the pain is refractory to the medical treatment, above mentioned medical treatment, in that situation, aromatase inhibitors, anastrozole, letrozole, these can be prescribed in combination with oral contraceptive, progestogen agonist, or GnRH antagonist. So, in refractory case of pain, we can add aromatase inhibitor to the above mentioned therapy. Now coming over to the surgical treatment for the endometriosis related pain. So for that, for relieving of the pain, if it is affecting the quality of life and not responding to the medical management, or patient is willing for surgery, and there is not a significant say not a significant lesion and minimal lesions are present, excision is advised instead of ablation of the lesion. That gives better pain relief and better postoperative effects in the patient. Previously used laparoscopic uterosacral nerve ablation, which was thought to be beneficial, it is not recommended now as an additional procedure to conventional laparoscopic surgery in terms of relieving the pain. And postoperative use, guideline says that if you are offering the surgery, that should be excision. There should not be, Luna is not required at all. After the excision surgery, if patient is not willing for having a family instantly, then there is, recommendation of post-operative use for 52 milligram levonorgestrel intrauterine system or combined hormonal contraception for at least 18 to 24 months for the secondary prevention of endometriosis associated dysmenorrhea. So for the prevention of dysmenorrhea, we should, even after the surgery, because endometriosis, we have to counsel the patient before surgery that surgery may not, completely relieve her pain, and post-operatively as well, she needs to use the treatment. But surgery can, to some extent, reduce the level. Completely of pain is not possible. So counseling will go on that line. And similarly, following that, we will offer the patient that post-operatively, at least for 2 years, she needs to take combined pills or levonorgestrel intrauterine system for the dysmenorrhea prevention and for the recurrence prevention. In case of ovarian endometrioma, more than 3 centimeter, cystectomy is advisable if patient is having pain. If patient is having severe pain at less than this size, then also cystectomy is advisable instead of drainage and coagulation, because drainage and coagulation leaves the cyst cavity, cyst wall there only, and it comes back again. Recurrence is very common because of the cyst wall. So cystectomy shows the promising effects in the endometrioma removal, in the pain relief, as well as for infertility. Cystectomy and carbon dioxide laser vaporization can both be considered, as both of the techniques appear to have similar recurrence rates beyond first year after the surgery. But early post-surgical recurrence rates may be lower after the cystectomy. So this whole was the can be the EMQ form, that the first year recurrence rate is similar in both of the procedures, but early post-surgical recurrence rate is lower after cystectomy. So the instant pain relief can be seen more in the cystectomy group. Now, for deep endometriosis, GDG says, in case of pain debilitating the woman, it is always better to refer these patients with deep endometriosis to the center of expertise. Multidisciplinary team need to be involved in the care of these patients, and surgical treatment is thought to be reducing the endometriosis associated pain, and it improves the quality of life. So even if it is a bowel or bladder endometriosis, it is advisable to take MDT opinion and offer patient surgical removal or excision of the lesions. Now coming on to the hysterectomy option. In this case, patient is to be counseled for the removal of ovaries. In this situation, patient is to be explained the early removal of ovaries and related effects, premature menopausal effects on the woman's health, as well as the persistence of the symptoms of endometriosis. So, hysterectomy with removal of all visible endometriosis after proper counseling of the woman who no longer wished to conceive and failed to respond to more conservative treatments that can be used as the last option in case of endometriosis. Women should be informed that hysterectomy will not necessarily cure the symptoms or the disease. So, uh, before removal of the ovaries, as I said, we need to counsel the woman for the consequences of early menopause and possible need of HRT and the persistence of symptoms. Total hysterectomy is preferred as compared to subtotal hysterectomy, and it is not recommended to prescribe any pre-operative hormonal treatment to improve the immediate outcome of surgery for pain. No pre-operative hormone treatment is prescribed. It is not recommended. Guidelines says this clearly, and a shared decision making between the hormone treatment and the surgical treatment, because endometriotic surgery for pain relief can be a double-edged sword. Patients need to be counseled very well and very properly. Pain may increase as well, so it should be a shared decision making between the hormones and the surgery. Acupuncture is considered a complementary and non-invasive treatment. So if acupuncture is also been studied extensively, and they are saying in the guideline that it can be considered. Uh, and coming to the non-medical management strategy for endometriosis associated pain, it says uh, there is no strong evidence for any of the non-medical management, so we cannot prescribe that to the patient, like any Chinese medicines, physiotherapy, exercise, uh, and acupuncture as well. They don't recommend that, but that can be considered in patient's care. But other therapies cannot be even considered, as the potential benefits and harms are unclear of these therapies. Now coming to the very important topic, that is endometriosis associated infertility. We all know the universal scoring system by the ASRM, that's ASRM. They have revised the scoring, ASRM scoring, that is American Society of Reproductive Medicine. They have given a universal score in 1996, which we are using till now by modifying it, and now the revised latest one. It is easy to understand and perform. They have given a performer when we do a laparoscopy in the patient. We we classify the patient woman for endometriosis in 4 stages. That is 1, 2, 3, and 4: minimal, mild, moderate, and severe. And American Fertility Society, AFS, that suggests some scores for all these, staging. If they score the picture inside, it scores 1 to 5 points, means there are superficial lesions or very small lesion that's less than 1 centimeter. We put it in stage 1. And if there are 6 to 15 points, depending upon the additions, site of additions, and the size of cysts, that can range from 1 to 3 centimeter, the patient will be in stage 2. Stage 3 will be having 16 to 40 points. That's more than 3 centimeter cyst size and dense additions. In stage 4, there will be complete obliteration of the pouch of Douglas. So that will be considered as stage 4. So after knowing this classification, we need to classify the infertility patient of endometriosis into its stage, and that stage will be considered for the treatment options for the woman. This is the chart which is to be filled by seeing the picture, and it will be given the scoring here. and we will divide it into the stage depending upon, we'll count the score, like in ovary, peritoneum, ovary, tube, posterior cul-de-sac. If it is completely obliterated, it has given here 40, so it is in stage 4. Yes, and that's depending upon the flimsy dense adhesions, endometrioma cyst, lesions. These will be given the score accordingly. And here is the pictures which can be filled after the surgery. Now coming on to the very important aspect and the huge collection for the SBAs and the EMQs, that's the treatment of endometriosis associated infertility. What is the role of surgery in the treatment of endometriosis associated infertility? So according to revised ASHRAM stage 1 and 2 endometriosis, this says operative laparoscopy. For the minimal and mild endometriosis, operative laparoscopy, that will be excision rather than ablation, cystectomy rather than drainage and coagulation, improves the rate of pregnancy, but no improvement in live birth rate. Here I just want to make it clear. I have told you about the cystectomy, but in stage 2, it is 1 to 3 centimeter only. So we do not offer cystectomy for infertility alone here. Okay, so if the endometrioma is only more than 3 centimeter, we offer cystectomy to the patient for improving the pregnancy rate. So here we offer the operative laparoscopy in terms of excision. It improves the rate of pregnancy, but no improvement in live birth rate, so not recommended in routine. Operative laparoscopy for the treatment of endometrioma increases the chance of natural pregnancy, but at the same time, it increases the chance of ovarian tissue damage as well because of surgery. So it has to be weighed correctly by the surgeon or clinician. Surgery for endometrioma prior to ART can be considered to improve endometriosis associated pain or for the accessibility of follicles as well. No evidence exists that operative laparoscopy for deep endometriosis improves the fertility, so it is not required to work upon that for infertility treatment. In infertile women with endometriosis, ovarian suppression treatment is not recommended at all. Giving hormonal treatment for ovarian suppression to improve the fertility is not recommended for treating infertility. Woman who doesn't decide to conceive immediately after the surgery, they can be offered the hormone therapy as it does not negatively impact their fertility, and improves the immediate outcome of surgery for pain. So we can offer the woman only in case she doesn't want to conceive instantly. So that will help in her pain as well, and to for the quiescence of the disease. Now, assessing the need for assisted reproduction after the surgery. For ART after surgery, the endometriosis fertility index should be used that we have just discussed, the scoring system. And for ASRM stage 1 and 2, we have just discussed that surgery can be considered after the surgery or without the surgery, intrauterine insemination with ovarian stimulation. This technique for assisted reproduction can be used in the patient for improving the pregnancy chances. It increases the pregnancy rate. In stage 3 and 4, means moderate to severe endometriosis, where tubal patency is uncertain, in this situation, IUI with ovarian stimulation could be considered, but that's not always going to help. So that in this stage 3 and 4, the uncertainty is here for the outcome of IUI. Now coming to ART in endometriosis and infertility, where low EFI is there, endometrial fertility index, it is low and other treatment have failed. There we can consider IVF in these patients. Both protocols, if question comes that which kind of protocol is preferred in terms of endometriosis with low patient going for IVF, there is no census or no evidence which suggests that anything is better than another. So both of the protocols can be offered to the patient. Recurrence rates are not increased in women who are undergoing ART. So patient is to be reassured that hormonal treatment or IVF treatment is not going to increase the recurrence of endometriosis later on. If there is a huge endometrioma, we can think of giving antibiotic prophylaxis at the time of oocyte retrieval. That is recommended. Extended administration of agonist is not recommended. It doesn't help. Now, coming on to the effect of pregnancy on endometriotic lesion, a common myth that pregnancy leads to improvement of symptom is not there. Patients should not be given this hope and should not be offered to get, advised to get pregnant for improvement of the symptoms. Complications that sometimes endometriotic lesions, they may change during pregnancy and can aggravate as well into malignant transformation. So any change in the appearance during ultrasonography should be considered a red flag and should be referred accordingly, according to the appearance. So complication that can be related to the endometriosis during pregnancy, there can be acute torsion if there is endometrioma, there can be pain, there can during pregnancy throughout, and endometrioma may even rupture. Increased risk of first trimester miscarriage, as well as ectopic pregnancy. That has these complications of early pregnancy in the woman who has endometriosis and conceived should be kept in mind. So this was all about the endometriotic lesions related to infertility and the pregnancy. Now endometriosis and adolescents. We should, though it is a condition for the reproductive age group, but it can also be as well found in adolescent groups. So the possible risk factors are to be kept in mind in treating an adolescent girl with the symptoms and signs that are suggestive of endometriosis. The possible risk factors, these could be positive family history of endometriosis, obstructive genital malformation, any transvaginal septum, early menarche, or short menstrual cycle. These can be the risk factor for the endometriosis. Careful history to identify these factors and the sign and symptoms. These can be chronic or acyclical pelvic pain as well, combined with nausea, and the cyclical dysmenorrhea, dysesthesia, dysuria, and dyspareunia, or cyclical pelvic pain. Examination, clinical examination, if it is appropriate for the adolescent, transvaginal can be considered by taking the appropriate consent from the girl or from the parents. Imaging, TDS is appropriate. Otherwise, MRI, transabdominal scan, transperineal or transrectal scan should be offered. In adolescents with suspected endometriosis, where imaging is negative and medical treatment have not been successful, as we do in as we have seen in previous slides for the reproductive group women, diagnostic laparoscopy may be considered. So treatment is just the same: NSAIDs, hormonal treatment, intrauterine systems, and GnRH agonist, as well as in the last, surgical treatment. Now, the most trickiest part is dealing endometriosis in postmenopausal women. Surgical treatment, low threshold can be kept for surgical treatment in postmenopausal women who are presenting in the signs of endometriosis. If a pelvic mass is detected, and we are suspecting even if as an endometrioma, the workup and treatment should be performed according to the National Oncology Guidelines. That is the difference here between the reproductive age group and postmenopausal. We'll follow the National Oncology Guideline in treating the pelvic mass for during the suspicion of endometrioma. So, if surgery is not feasible for pain, aromatase inhibitors can also be offered to the postmenopausal woman. Now, if a woman has a history of endometriosis and she has a menopause, having the symptoms, we will offer combined menopausal hormonal therapy rather than estrogen only disease, because that can be associated with higher risk of malignant transformation of the endometriotic lesions, as well as the recurrence of the uh, endometriosis associated pain. Women with surgical menopause offer the combined estrogen progesterone at least up to the age of natural menopause. So this is recommended in this guideline. It has been said that we need to offer till the age of natural menopause, and we should do the proper counseling of the woman also. Coming on to the extrapelvic endometriosis, watching over the symptoms which are cyclical and imagings which are showing any nodules in the organs that enlarge during menses, that can give rise to the suspicion, and imaging in the form of MRI and ultrasound scan can be added in the diagnosis. Patient should be referred to the multidisciplinary team in the centers with sufficient expertise, because it can be very tricky and can lead to many complications due to the involvement of the vital organs as lungs, so, and the bowels. Excision is the treatment of choice. Here, out of our belief that we can give hormones that would be better in controlling the size of the lesion, guideline says excision is always the treatment of choice. In case of extrapelvic abdominal endometriosis, umbilical or inguinal endometriosis, excision is always the treatment. Hormonal treatment only in case if excision is not at all possible, expertise is not available. So for the waiting period, we can give the hormones. Now the question is, if we are doing a scan and we incidentally we are incidentally finding an asymptomatic endometriosis, do we need to do any treatment for that? So the answer is no. Guideline says there is no benefit of treating asymptomatic endometriosis. For follow-up of this endometriosis, to check for the malignant transformation, routine ultrasound monitoring, it can be considered depending upon the extent of the endometriosis. So no evidence of benefit for the prevention, because we cannot do anything. Though guideline says that women can be advised if she has any high risk factor, like a family history, like any obstructive genital lesion, like if she has any early menarche, we can advise the woman to opt for a healthy lifestyle with diet, with reduced alcohol intake, with regular physical activity. But at the same time, we can assure that patient that there is no role of any intervention in the prevention of endometriosis. Again, a very important topic for the questions for EBCOG part 1 as well as MRCOG part 2, the link between endometriosis and cancer. Endometriosis is associated with a higher risk of ovarian cancer, particularly clear cell cancer and endometrioid histotype, breast cancer, and thyroid cancer. Increase in absolute risk compared with women in the general population is low. So we have to explain this to the women as well. But if question comes, does it increase the risk? Yes, it increases the risk of ovarian, breast, and thyroid. And in ovarian, particularly clear cell and endometrioid subtype. Most common is clear cell. Clinicians should reassure women about the risk of malignancy associated with the use of hormonal contraception, because these patients have recurrence and long-term pains for that patient need to be, for the long term, they need to be on the hormonal contraceptions. And we all know there are greater studies on the use of oral contraceptive pills for and the effect over the different type of cancers. It protects the woman 20 to 30% than the general population in reducing the risk of ovarian cancer, oral contraceptive pills. And if taken for 10 years, it will reduce the risk by 40% even. But at the same time, it increases the risk, put the woman at increased risk of cervical cancer as well as breast cancer. So that has to be considered in the counseling. Now, we will be summarizing the guideline. The diagnosis of endometriosis we have learned. We will be doing, in this it has been clearly mentioned, biomarker testing is not recommended here. We are doing the clinical exam and along with the history and imaging, ultrasound or MRI. So after, if imaging is also negative, we will do the laparoscopy. Even if the laparoscopy is negative, we can do the and histology is negative, we can still give the treatment of endometriosis to the woman on the basis of the suspicion. So treatment for endometriosis, that's basically the pain, main symptom, cardinal symptom is pain. So we have discussed NSAIDs, analgesic. We have discussed the hormonal treatment, and then we have discussed the surgery and consideration of post-operative hormonal treatment. So what kind of hormonal treatment we are opting for the woman? Combined hormonal, oral vaginal ring or transdermal, continuous use of the hormonal contraception, then progesterone, agonist, antagonist, aromatase inhibitor as third line treatment or in refractory pain of endometriosis. GnRH agonist, add back of combined hormones should be considered. GnRH agonist is the second line due to the side effect profile. So first line is combined hormonal contraception and progesterone. Aromatase is the third line. So coming on to the infertility, there are different options. Hormonal treatment, not at all recommended, which we are giving in pain as the main treatment modality. Here in infertility, we do not select it. There are options, but sheer decision making is to be done for the surgery and for the assisted reproduction. So surgery to increasing the chance of spontaneous conception in case of revised ashram 1 and 2, and assisted reproduction in case of very low EA5, revised ashram 3 and 4, as well as if she is not responding or conceiving spontaneously. So in those cases, we are offering assisted reproduction. And endometriosis and pregnancy, increased risk of first trimester miscarriage and ectopic pregnancy, and possible association with increased, mostly rare risk of obstetric complication. So we are here bothered only about the first trimester miscarriage and ectopic. That we have to keep in mind. And that's all about the most important points of this guideline. Guideline is huge, but I have tried to compile it so that the maximum benefit it can offer you. And we have a quiz ready in our EBCOG 1 group. So all of you can go and take the quiz, and quickly you can revise whatever we have read just now, and you will see that most of the questions which are there you will be able to solve through our through our these slides. So that's all about endometriosis, and I really wish that you all should come out with flying colors in EBCOG Part 1, and best wishes from Rayz Academy. We are planning to conduct a marathon before your exams, so anybody will be interested can let us know, and we'll manage that according to the date suitable to all of you. Any questions anybody has?
Yes, Dr. Heath, about the last part you mentioned, I didn't get.
Shall I show you the slide?
No, not the slide. I mean, you mentioned something after the MRCOG. What did you mention after that?
Okay. About the course marathon. About
Uh-huh.
the 5 days, like we are planning to get a 5 days marathon, which we conduct for MRCOG Part 2 as well and for Part 3 as well. So for EBCOG Part 1, 2, 1 also, we are thinking of conducting a marathon course of 5 days only, so that to quickly cover all the important topics which you can find beneficial for the exam. So that will be only a revision.
Okay, and whom we can contact to know more details about it?
Yeah, you can just message in the group and we'll get back to you. Our team will get back to you.
Okay, thank you.
Okay. Yeah, thank you so much. Anybody, if you have any questions, we are open for any queries. You can send in the group, and please, please, please go and solve the quiz. It is waiting for all of you. We have posted it today only because we thought that after the session you'll be able to solve it and it will boost up the confidence. Yeah, all the best. Thank you so much.